Hello everyone, and welcome to another chapter of Pediatric Primary Care. Today we're talking about Chapter 11, Developmental Management of Early Childhood. Developmental changes in early childhood, meaning our 1 to 5-year-olds, are more subtle than those seen in the first year of life, yet they are highly significant. Early childhood is especially marked by rapidly developing psychosocial skills. Children enter the stage as toddlers, very dependent on parents and caregivers for their survival, and leave as accomplished preschoolers with skills to enter the social world of school and community, and a sense of self that shapes the quality of their character for the rest of their lives. This chapter reveals many of the changes that occur in early childhood, the common issues encountered, and the role of the primary care provider when working with these children and their families. Starting off with developmental overview of early childhood. The physical growth and development. Primary care providers use the World Health Organization growth charts to monitor growth up to until 2 years of age, then shifts to the Center for Disease Control and Prevention growth charts for children 2 years of age and older. Around this time of this shift, the average 2-year-old weighs about 28 pounds or 12.7 kilos, is approximately 34 inches tall or 86 centimeters, and has a head circumference of approximately 18.5 inches or 47 centimeters. There may be a small discrepancy in percentiles as children are now measured standing rather than supine. The anterior fontanelles should completely close between 18 to 19 months, while the body's skeletal growth continues especially during the 4th and 5th year. As additional ossification centers appear in the wrist and ankles, and additional epiphyses develop in some of the long bones. Organ and system maturation. Specific changes in the body systems during early childhood are highlighted in Table 11.1. Motor development. Advances in gross motor skills, the use of large muscles, and fine motor skills, the hand, finger, and oral motor development, are summarized in Table 11.2. Hand dominance usually develops between 2 and 4 years, but may not be evident until 4 to 6 years of age. Social and emotional development. These are years of intense learning about identifying and managing feelings, love, happiness, anger, frustration, aggression, and jealousy, and developing social skills, sharing, giving, and receiving affection. Emotions and cognition are interconnected as this age group learns the words that go with their feelings, and with guidance, the appropriate corresponding actions and behaviors. A major developmental milestone for this age is the achievement of a sense of independence and autonomy. The road from depending on parents, caregivers for everything, to doing some things for themselves can be rocky and uneven. A child's ability to achieve independence is influenced by the positive strengths, protective factors, and negative influences, adversity, in their environment. For example, adverse childhood experiences and household dysfunction can cause short and long term impacts on childhood development, disease risk, and social problems. Feelings and emotions. Children in early childhood need a great deal of love, warmth, and comfort, primarily from the parents. 1 to 2-year-olds learn to give love and find satisfaction in pleasing their parents. They learn to respond to kisses, hugs, and cuddles they receive by giving kisses, hugs, and cuddles in return. Children who attempt giving love and are rejected or ignored soon stop trying and learn to find pleasure elsewhere. However, children with sensory issues avoid some gestures unless they are in control and decide that they can handle the tactile or sensory feelings. Some 1 to 2 year olds find that thumb sucking, rhythmic body movements, and body manipulations are more pleasurable and reliable than person to person contact. 3 to 5 year olds gradually develop more sophisticated ideas about feelings, giving and sharing as they move away from the self centered attitude of toddlerhood and focus more on the pleasure pleasing behaviors. At this stage, parents are and should model the epitome of wisdom, power, integrity, and goodness. Children who do not feel loved often respond with an increase in fears, inhibitions, explosive behavior, and demands for attention. So here is table 11.1, which talks about some of the changes in body systems in early development, whether it's dental, neurologic, cardiovascular, pulmonary, GI, renal, or endocrine. A good spot to hit pause just to kind of get a review. And as always, if I'm ever going too quickly, please hit pause. Social competence. Children gradually increase their ability to follow commands as they work to gain and maintain adult approval and behave the way they learn good children are expected to. By 3 to 5 years, children begin to show interest in table manners, being polite, saying thank you without a reminder, sharing, saying and meaning I'm sorry, and taking turns. These social skills are learned through daily interaction at home, as well as other social exposures, such as at preschool and church, and through those around them, including parents, caregivers, siblings, peers, relatives, teachers, and neighbors. Children begin to realize that others have feelings, fears, and doubts. They learn to read others' social cues, the voice tone, facial expressions, and posture, and to self correct their own behavior. Some children find interpreting others' cues challenging, such as empathetic recognition, and parents can help by modeling, explaining, and discussing cues with them. Self control and autonomy. Throughout early childhood, children facilitate between being a big boy or girl and being mommy's and daddy's baby, taking pride in doing as many things as possible for themselves, yet still needing to feel totally secure in their parents' care. On some days, 1 to 2 year olds cling to their parents' side, not letting them out of their sight, while on other days, the child can play for short periods in the next room, trotting back every so often to see, touch, and hear the parent and be reassured by their presence. The child who feels secure uses the parent as a base from which to go out and safely explore the world. Gradually, the periods of separation lengthen, and the child needs only to hear the parent's voice or to check occasionally for security. Separation anxiety occurs during these years and can be traumatic for both the parent and the child. Having a choice and learning the power of the word no emerge early on. Younger children can become extremely negative, practicing the power of no every day for months, even when their answer is actually yes. They practice making choices, but they are clumsy, awkward, and frequently wrong. This can be frustrating for them, and their outraged responses can be equally frustrating for parents. 1 to 2 year olds discover the delights of control over others and themselves. This control not only increases the sense of power, but also leads to misunderstandings and hurt feelings if their parents do not read their moods properly. During early childhood, children become more skilled, make better choices, have more successes, and feel more powerful. They no longer have to work so hard to show others their power, and the dominantly negative phase passes. 3 to 5 year olds are much less dependent on their parents and frequently tolerate physical separation for several hours. As their sense of separateness increases, children are more aware that they are different from their surroundings, families, and friends. Learning about how to have and be friends is challenging, but significant. Interactions become easier and more enjoyable as the child learns to verbally express needs and feelings. They are also able to perform increasingly more self care tasks, feed themselves using appropriate utensils, blow their own noses, and go to the bathroom unassisted. So here we'll go back up so you can take a look at some of the fine and gross motor development milestones for early childhood. Again, here's a good spot to hit pause so you can take a look and see. Now I'll also scroll down in just a moment so that you can see as much as you possibly can. Again, if I'm ever going quick, just hit pause. Play and peer relationships. 1 to 2 year olds may be fascinated by children their own age and demonstrate curiosity by physically examining the other child closely, poking and probing. However, they generally do not engage in an interactive way. Parallel play is the norm. 3 to 5 year olds learn to interact with peers, especially as symbolic language develops. As their social world grows, play is more interactive, cooperative, and shared. Play offers more than cherished memories of growing up. It also allows children to develop creativity and imagination while developing physical, cognitive, and emotional strengths. Fantasy and make believe are also important during these years. Imaginary play leads to pretend play, role playing, and creation of imaginary friends, all of which allow children to work through challenges. Play is the major mechanism through which children in early childhood practice social roles, such as housekeeping, caring for baby dolls, fixing household items, going to work or school, cooking, practicing religious or cultural rituals and practices, and doing garden or yard work. Children need both structured and free play. Shared or cooperative play makes simple games of hide and seek and tag possible. Games with complicated rules can be frustrating for the 3 to 5 year old child, who prefers simple games, with the option of making up the rules as the game proceeds. Cheating is common because boundaries of acceptable play are not yet clear, and the earliest stages of moral behavior are beginning to emerge. Environmental factors can affect a child's ability to make healthy play choices. Children today spend less time playing outside than previous generations, and they are more likely to play in their yard than any other location. Larger neighborhoods environments can impact children's access to the natural world, outdoor play, and physical activity, creating environments with easy access to nature trails or outdoor play. Equipment increases exposure to the natural world and different types of physical activity. Safe spaces occur when there are fewer connecting streets and more visually appealing play areas are attractive to children and parents. However, any outdoor activity exposes children to the natural world and its unique form of stimulation. Moral development. The ability to know right from wrong is based on evolving external controls as well as from children's evolving desire to please those they love. 1 to 2 year olds cannot be expected to make correct choices if left alone in potentially dangerous situations, because their conscience is rudimentary and judgment is absent. For example, any room with electrical sockets, knobs for technical equipment, guns, open windows, unsecured televisions, and furniture or hot food represents a risk. As children gain language skills, they begin to echo their parents' firm no, but they do not fully understand its meaning. By age 2, children show beginning internalization, often saying no to themselves as they proceed with or stop the act. As they develop, 3 to 5 year olds establish a moral foundation that is more internally controlled. Instead of basing all decisions on knowledge of and consequences of an act, children begin to show an elementary understanding of justice, which includes what is right and wrong, as well as what is fair or unfair. They recognize others' needs and can help or comfort others. They begin to think ahead as well as plan and control their urges, thus avoiding punishment. By age 4, most children internalize some demands from their parents, and feelings of guilt can be elicited after some transgressions. In the long term, children's successes and failures at controlling their words will impact their immediate and future behavior. Parents often worry about how to help children develop decision making skills. The recommendation is to focus more on helping the child to make safe decisions first. The moral ones will follow. Body image. 1 to 2 year olds realize that they are separate persons and begin to notice their own bodies. They are fascinated with body function and may also become fascinated with sex and gendered differences. Bodily injury becomes a concern, and cuts and bruises elicit much discussion and often warrant attention. 2 to 3 year olds increasingly notice the inner signals, such as the urge to move the bowels and release and relaxation resulting from going to the bathroom, the discomfort of hunger, or sense of feeling full. 3 to 5 year olds' curiosity about their bodies continues as they learn to understand and express themselves. Curiosity about their bodies and those of others generates a wealth of innocent questions. They frequently examine and re examine themselves, sharing worries over a skinned knee, cut, bruise, discoloration, as well as their first loose or lost tooth. Masturbation is a continuation of discovering parts of their body and the pleasurable feelings it elicits, and it's very typical behavior during early childhood. Cognitive development. Cognitive development of 1 to 2 year olds thinking is highly concrete. According to Piaget, 18 to 24-month-old children use mental imagery and infer causality when they can see only the effect. For example, if they see a puddle of milk on the floor, they might say, uh oh, because they assume it was spilled by someone. By age 3 years, children enter the pre operational stage with pre conceptual and intuitive thinking. Primitive conceptualizations processes begin with the development of symbolic thinking. An example is a block becomes a car, words become symbols for ideas. They develop symbolic thinking, which manifests their drawings and acting out elaborate play scenarios. However, children at this age generally are unable to take another's perspective, instead continuing to view the world egocentrically. Attending to one characteristic at a time is another feature of 3 to 5 year old thinking. Another example is the child will try to fit a jigsaw puzzle together using either color or shape, but not both. Parents may have difficulty understanding a 3 to 5 year old's thoughts. On the surface, pre-operational thinking has many characteristics of adult thinking. The parents may misinterpret this and believe children are now able to think as adults do. For example, as children develop their use of language and the ability to symbolize concepts mentally, some of their verbalizations appear quite precociously, as evidenced by the child who stares out the window and then states, "Look, mommy, the trees are saying yes and no." Table 11.3 identifies major characteristics and examples of children's thinking in early childhood. One of the most sensitive indicators of cognitive development is language development, and many assessment tools plot language ability as a way of measuring cognitive levels. Again, as noted earlier regarding social and emotional development, assessment of one's developmental area is somewhat arbitrary. Again, an example would be social development and adaptive skills are major indicators of cognitive abilities. Differentiation of the self from others with increasing sensitivity to the rules and norms for social interaction and the perspectives and feelings of others requires ever increasing cognitive capabilities. In addition, play, quality is an indicator of cognitive development, as children manipulate and learn to control their environment in a safe yet stimulating manner. Which brings us to Table 11.3, pre-operational stage characteristics and examples of the 3 to 5-year-old thinking. Communication. Language and communication development during early childhood is fundamental to social, cognitive, and academic growth. At 15 months, children speak few words, but understand many. Thus, their receptive language is considerably greater than their expressive language. During Piaget's pre-operational stage, children typically think symbolically, and language becomes more mature. Beginning around 2 years of age, children use words to convey their thoughts and feelings. Rich reciprocal communication may be the most important speech development factor through early childhood. It is important to remember that hearing is vital to speech development and should be monitored. While each child develops speech at different rates, Table 11.4 will list common speech and language milestones. Cognitive development is required for language development because the child must decipher language rules independently, problem solve to understand other communication, and create symbols so their ideas and emotions that can be understood by others. Literacy programs, including Reach Out and Read, as well as the informal efforts through parental reading aloud, fosters language growth. Language development requires mastery of the following four. 1. Oral fine motor ability to articulate sounds. Auditory perception to distinguish words and sentences. Cognitive ability to understand syntax, semantics, and pragmatics. Psychosocial cultural environment, providing opportunity and exposure to engage in language use. Language milestones occur in two general categories, receptive and expressive. Understanding these milestones includes taking a closer look at the development of speech, including articulation, lexicon, syntax, semantics, and bilingualism. Articulation. Young children practice articulation skills daily, and by age 2, sounds are 50% intelligible to strangers. The intelligibility rate jumps to about 75% by 3 years of age. By 4 years, speech should be completely intelligible, with the exception of particularly difficult consonants. However, these tongue contact sounds of T, D, K, G, Y, and N become more intelligible by age 5 years and school entrance. Sounds such as C are not added until the child is older. Children usually progress through a regular sequence of mispronunciations as they learn new articulation skills. At first, they omit the new sounds and they try to substitute a more familiar sound for the new one. Distortion is followed by addition as the child adds the extra sound. Knowing each of these steps allows the examiner to assure the parent whether the child is developing appropriately or needs additional monitoring. Figure 11.1 identifies sounds articulated at a specific age. Here we'll jump back up here for just a moment and you can take a look at the language development of early childhood. Related to specific sounds are pitch, hesitancy and stuttering, and disfluencies. The 2-year-old practices playful changes in pitch and loudness. 3 and 4-year-olds show typical hesitance in speech or stuttering. Stuttering may occur as the child develops language skills. They stutter by repeating words, especially those at the start of a sentence or when excited, such as when they want to convey an important message. This speech variant is notable in that it does not include syllable repetition, while developmental disfluencies are typically temporary. They are concerning if they cause significant stress for the child, last longer than 6 months, occur in a child over 5 years of age, or if they involve a syllable instead of word repetition. And here's another good spot where you can see the age of customary consonant production. Lexicon. A child's vocabulary, or lexicon, is influenced by many factors, including environment, stimulation, intelligence, multilingualism, culture, and personality. As noted earlier, in early childhood, child's receptive language is far greater than their expressive language. The addition of words to their expressive vocabulary comes with ongoing exposure and practice. Female children typically say their first word between 8 and 11 months, and males at about 14 months. Most 2-year-olds have more than 200 words in their vocabulary, with 4 to 5-year-olds adding approximately 50 words a month to their vocabulary. In addition, 5-year-olds can define some words using other words. Syntax. Syntax, or grammar, refers to the word structure in sentences or phrases. The ability to construct sentences that convey meaning is a complex skill, proceeding through several stages, including receptive, holophrastic, and telegraphic speech. Syntax skills begin to develop in late infancy and continue through early childhood. At the beginning of early childhood, children use hollow phrases or single words to express a complete sentence or complex idea. An example is a child will say milk to convey "I want a glass of milk." These holophrastic sentences are typically denominative or imperative. Around 18 months, children begin using telegraphic speech, or phrases that may have words omitted and sound like a telegram: get milk, or go bye-bye. By age 2, children begin to expand their vocabulary and to form short phrases involving adjectives, like my big ball and the yummy cookie. Children will mimic phrases and gestures used by caregivers, like oh my goodness. Their sentence structure continues to become more complex as they move from active sentences to questions, passive negative constructions, and adding plurals. And past tense. 3 or 4 word sentences should be evident by 3 years. Syntax is close to adult style by 5 years. By the end of early childhood, they also use future tense in complex sentences, 5 to 6 words in length. Semantics. Semantic development, the understanding that words have specific meaning and that the child's use of words to convey specific meaning, is an ongoing process that extends into adulthood. It occurs in stages, moving from global to more specific, and requires interactive through conversation, listening, and reading. Words have both denotative and connotative meanings. Even though children may be adept at using words correctly, they may have only a vague, diffuse connotative understanding of these words. So an example is the child who drops a toy and uses an expletive that she heard when her father dropped a dish does not understand the connotative meaning. As a child's overall language progresses from simple to more complex, semantic and cognitive understanding evolves. Bilingualism. Raising children to be bilingual helps preserve the family culture and heritage, and studies suggest that bilingual children have greater mental flexibility and enhanced employment and lifestyle opportunities. Parents who ask primary care providers how to best introduce 2 languages to children are often told to use the one parent, one language approach, where parents speak in their native language when conversing with the child. While this approach has some supportive evidence, the number of families who follow this advice has not been documented. Children who learn 2 languages at the same time may have smaller vocabularies in each of their languages, but the sum total for both languages should be equal to that of children who are monolingual. An example, children from bilingual homes may show mild delays in initial spoken words and a mixing of words and phrases from the two languages. However, most children are able to proficiently sort one language from the other, although they may code switch to the other language for clarity. They become flexible, switching languages depending on the circumstances and the person with whom they are speaking. Some children even translate for others, understanding that not everyone speaks or understands both languages. Ultimately, whether a second, a third, or even more languages are learned simultaneously or sequentially, most children have one dominant language. The challenge for primary care physician is to diagnosing true speech and/or language delays in bilingual children. To date, there is no evidence that links bilingualism to language delay. Instead, speech delays are not typically related to factors including multiple ear infections, hearing loss, anatomic abnormalities, neurologic impairments, injuries, or more. If the primary care physician suspects a language delay, further exploration is warranted. Common developmental issues in early childhood, such as sibling rivalry. Sibling rivalry involves the realization by one child that they must share the parent's attention and affection with their siblings. It can continue in varying degrees over time, but at each age the child may feel threatened or displaced. Interaction patterns between siblings vary and are affected by individual and family characteristics, such as sex and gender, age, temperament, degree of attachment, nature of family interactions, discipline used in the family, and the child's perception of the equality of a parent's treatment of each child. When siblings argue or fight amongst themselves, parents need to stop the activity, describe the situation, and provide even-handed direction, while providing options or compromise actions. Blaming one child, except in a clear-cut instance of misbehavior, is usually non-productive. Instead, the focus should be on promoting sibling support, loyalty, and friendship. To assess sibling rivalry, ask parents to describe sibling behavior of concern, fighting, verbal abuse, bickering. Identify precipitating events or situations that elicit negative behaviors. Reflect on how sibling rivalry behaviors between siblings were handled in the past and encourage the siblings to resolve the issues between them rather than the parents. And finally, describe how they reacted to the behaviors or verbal comments, and if or how they have disciplined the child. The introduction of a new sibling by birth or adoption is a life-changing experience for the older sibling. The developmental stage of the older sibling is an important consideration in helping parents prepare. Some children in early childhood regress when a new infant arrives, while others experience excitement, love, and enhanced self-esteem. Parents must address any aggression expressed by the older child, and at the same time provide love, attention, and opportunities to talk about their feelings. To assess sibling rivalry after the arrival of a new infant, ask parents whether the older child has regressive behaviors since the new sibling arrived, made negative comments about the new sibling, or has demonstrated verbal or physical aggression towards the parents or new sibling, or voiced psychosomatic complaints. The cornerstone of sibling rivalry management is anticipatory guidance and prevention. The primary care provider needs to prepare parents before the arrival of new siblings for the possibility of siblings rivalry and guide them in managing the situation. Before delivery or adoption, explain to parents that at the time of the arrival of the new baby or the other sibling may exhibit regressive behavior. Encourage the parents to do the following. Tell the child about the pregnancy or adoption of the new baby, using a time frame and language appropriate to the child's developmental stage. Investigate the possibility of sibling preparation classes for older siblings. Prepare the child for change in daily routine and change in the amount of time they will have with the parent. Give children realistic expectations of their interactions with the baby. Include an older child in preparation for the new baby and in the excitement of the event. And once the infant or child comes to the home, so afterwards, encourage parents to consistently spend alone time each day with the older sibling. Have parents include the older sibling in the care of the new baby as appropriate. Reinforce the older sibling's efforts to be the big brother or sister, and praise the child for helping. Explain the need for tolerance when the child exhibits regressive behaviors, knowing the behaviors are not permanent. And finally, educate parents about teaching children to distinguish between acceptable and unacceptable behavior, as well as accountability for negative behaviors. As siblings grow, parents should avoid intervening for minor squabbles. Rather, they should encourage child-centered articulation of more significant arguments and intervene primarily if physical or verbal abuse occurs. Box 11.1 has other strategies to help siblings develop healthy relationships. Which brings us to temper tantrums. All parents struggle with a child that has a temper tantrum. These unplanned outbursts of anger and frustration can be physical, verbal, or both. However, they are always disruptive and include unpleasant behavior. One way to approach tantrums is to tell parents their child is acting this way because they need or want something, but cannot express themselves with words, so they get frustrated, then angry, and ultimately lose control of their feelings. Temper tantrums and disruptive behaviors are discussed in more depth in Chapter 6. Toilet training. Toilet training occurs in early childhood. It is typically complete by the time the child is 4 years old, with a variation of up to 1 year for individual children. Children typically first learn nocturnal bowel control, then daytime bowel control, daytime bladder control, and finally nocturnal bladder control. Successfully toilet training requires sensitivity, understanding of development, good communication, hope, humor, and patience. In addition to becoming self-sufficient in their toileting, children should also learn that elimination is a natural and necessary process. As self-toileting is mastered, both parents and children should experience pride and satisfaction in having worked together to accomplish an important developmental task. The primary care provider plays an important role in providing anticipatory guidance to parents. Introducing the topic of toilet training by the 15 to 18-month visit is common, along with assessing parents' expectations and plans. This provides ample opportunity for discussion and possible development of realistic toileting outcomes. It can also be useful to remind parents that toilet training is not related to or indicative of the child's intelligence. When parents ask about the best time to start toilet training, the primary care provider should emphasize that every child is unique, and readiness cues should ultimately be used to decide when to begin training. Physiologic readiness develops by about 18 months. True voluntary sphincter control is a function of psychologic and social development as well, so most children are not ready for independent toilet training until about 24 months of age or older. Guidelines for assessing toilet training readiness includes physical, cognitive, interpersonal, or psychological, and parental skills. It is also essential that parents understand and can express to children that the goal is to use the toilet, not to hold in urine or stool. This is an important distinction, as holding of urine and stool can lead to bowel and bladder dysfunction. Primary care providers need to understand family practice and can be open to developing mutually agreed upon approaches to toilet training. Many cultures start toilet training earlier or later than what is typically practiced in the US, and toilet training strategies vary widely. As such, it is critical to understand parents' expectations for the process. If begun too early, toilet training can be very stressful for both parents and children and can contribute to family dysfunction. Further, starting independent toilet training too early may contribute to holding urine and stool, which can lead to daytime wetting, incontinence, and constipation, while starting too late may lead to dysfunctional voiding. There is little evidence regarding which, if any, toilet training strategy is most effective. When children and parents are ready to begin toilet training, several management techniques can be helpful. In general, though, it appears that a structured yet flexible approach that is responsive to the child's cues is likely to be most successful. Reassure parents that this needs to be individualized to each parent and child, a dyad, and may be different for its siblings. So here's box 11.1, the managing sibling rivalries do's and don'ts. And then 11.5, toilet training readiness assessment. And while we're focusing on these pauses, we'll also look at box 11.2, management of toilet training. Parents can become extremely frustrated if their expectations do not match the abilities and performance of their children, and child abuse related to toilet training may occur. The primary care providers play a crucial role in making the experience a positive one and preventing abuse by giving parents information about child development techniques for managing and training process and support and encouragement for their effort. This includes proactively doing follow-up with families who express frustration or appear to be having a difficulty with the toilet training process. If children resist training, the effort should be put on hold for a few weeks before trying again. Again, it's important to stress to parents that none of these holds should be viewed as a failure or for either child or parent. If a child is toilet trained for a brief period and suddenly regresses to wetting and swelling consistently, they should be placed back in diapers and the process begun again within a few weeks. It's extremely important that parents and children do not become engaged in a battle for control over toilet training. The primary care provider should emphasize to parents that they should never ask the child, "Do you need to go potty pee?" and so on. The answer will always be no, and thus an immediate battle ensues that is not even about the actual toileting. It is important to remember that it is the child's responsibility to control their bowel and urinary function, and toilet training is only one of the many tasks children master on their way to independence. Parents have the responsibility to assist in the process by providing a positive environment and opportunity, teaching the techniques, and setting a positive example. Childcare and preschool. Either or both parents often have to return to work during the first few months or years of the child's life. In 2019, 59% of children under the age of 5 attended at least one weekly non-parental care arrangement, with a reported 62% attending a daycare center, preschool, or pre-kindergarten setting. In 2021, 65.6% of mothers with children younger than 6 were employed, and 75.5% of women with children between 6 and 17-year-olds were employed. Childcare issues can be a source of significant parental concern. Parents are challenged with evaluating and selecting a qualified childcare provider who provides a safe, nurturing, and developmentally appropriate setting. The individual needs of the child, together with parental needs for work coverage and flexibility, must be matched with the philosophy and constraints of the childcare setting. The primary care provider is often called on to advise parents about how to select a suitable provider. Entering preschool can be stressful for both the children attending the school and their families. Some children have difficulty adapting to a more structured school environment, whereas others are comfortable with limits and rules. Parents may find that their child, compared with the other children and the child with a developmental delay, may be singled out as different, not fitting in, or as having a behavior problem. Preschool and kindergarten were originally intended to help children learn separation, sharing, listening, paying attention, and simple social skills. Today, kindergarten students are often expected to show pre-academic skills, which would include writing, counting, and letter and word recognition, in addition to the preschool social skills of paying attention and sitting still. In making their preschool selection, the primary care provider can remind parents that a play-based learning curriculum is the most comfortable way for children to learn during early childhood. When selecting a preschool, parents should also consider their children's characteristics, including their social skills, language skills, whether it's both expressive or receptive, physical size, energy level, neurologic maturation required for fine and gross motor activities, and neurologic maturation of sensory and cognitive function. Health supervision and surveillance. The health visits. Developmental assessment is an essential part of each health supervision encounter. Early identification of developmental and behavioral problems is key to provide early intervention. The process begins by establishing a rapport with the parents, reviewing data through interviews with parent caregivers, standardized screening tools, observation of the interaction between the child and the parents, physical exam, and lab rec, or other diagnostic measures. If there are concerns about the child's development or if the child is identified through screening as having a potential problem, a thorough diagnostic assessment is required. Referral to an appropriate specialist should be made to determine the degree of developmental delay and to identify intervention strategies. Box 11.3 here shows the 5-step approach to help parents select a child care provider. Continuing on with screenings. Children require screening for delays in their progression of gross and fine motor skills, communication and language, problem solving, and social and emotional and cognitive development. Screenings can be conducted at health supervision or at visits for episodic illnesses. Validated screening tools provide quick, inexpensive methods of identifying potential delays or concerns. These tools are generally appropriate for all children, although culture and experience can affect outcomes. Parents can complete a screening tool in the waiting room, or the PCP can directly ask them questions. PCPs should ensure that they understand the parents' responses and clarify any concerns. Table 11.6 will list a variety of developmental screening tools. Tables 11.7 through 11.10 list questions and rationales that PCPs can use to assess behaviors. Physical development. Children should have annual anthropometric measurements. They should also have blood pressure readings beginning at age 3 or earlier for the at-risk child. Hearing screenings should continue through the early childhood period, especially if the child has frequent ear infections or language issues. Age-appropriate visual acuity measurements is recommended starting at 3 years of age. Dental screening should be ongoing and will be discussed more in Chapter 20. Motor skill development. During early childhood, children develop and refine their motor skills, driven by curiosity, a desire for independence, and endless energy. Asking parents about their child's development is an important part of surveillance. Gross and fine motor skills are best assessed using standardized, validated screening tools, such as the Ages and Stages Questionnaire 3. Fine motor skills are evaluated by assessing finger, hand, and oral movements. while gross motor skills are evaluated by assessing large muscle abilities, such as the ability to sit, crawl, walk, run, hop, skip, and climb. The quality of the child's movements during these activities is important to note as well. Social and emotional development. Assessment of social and emotional development includes exploring the child's role in the family, success making friends, and interacting with peers, self esteem, and feeling of content and security. The social emotional section of the ASQ3 assesses these behaviors, but a more comprehensive screening can be done by using the Ages and Stages questionnaire. Social emotional 2 for children 3 months to 5 years old. The Pediatric Symptom Checklist is another validated screening tool that can be used beginning at age 4 to screen for cognitive, emotional, and behavioral concerns. Cognitive and intellectual development. As children thinking moves into the preconceptual stage, cognitive development is increasingly expressed through symbol systems and language. Children enjoy stories, make believe, and they become masters at games involving pretending and fantasy. Communication and language development. Communication is a vital part of being a happy, functioning human being. A careful history of the child's abilities and learning patterns provides much of the essential information. Listening to children and talking with their parents are essential, but the PCP should remember that parents may not be fully attuned to speech problems because they are accustomed to hearing the child's speech. Physical examination helps to determine if physical structures necessary for speech are intact. See Table 1111 for speech and language evaluation tools for use in primary care. Language screening needs to evaluate expressive and receptive language skills. Because language and cognitive skills are intricately interwoven, most intelligence tests have language sections that are also useful. Expressive language screening emphasizes articulation and vocabulary. Receptive language screening focuses on comprehension, repetition, and following up after spoken language. Which brings us to the anticipatory guidance for early childhood. But before we start that, here is that screening tool during early childhood. This is the questionnaires, and again, a good spot to hit pause. Anticipatory guidance during early childhood focuses on facilitating children's transition from being highly dependent to establishing a sense of autonomy, with an evolving understanding of the self as a separate, creative, and powerful being. During this process, parents continue to learn new communication and interaction skills with their children. Although the childhood years can be frustrating at times, the ultimate outcome of good communication and relationships that support the potential of both child and parent is worth the effort. According to the American Academy of Pediatrics, recommendations for preventive pediatric healthcare and the Bright Future Guidelines, PCPs should offer anticipatory guidance in the following areas: family support, childhood development, mental health, healthy weight, nutrition, physical activity, oral health, healthy sexuality, development of sexuality, safety and injury prevention, and social determinants of health. They should also provide education, counseling, and support services. Specific topics are discussed below in more detail. So here are a couple more tables. Table 11.7, surveillance of physical development and motor skills, the questions and rationale. Table 11.8, surveillance of communication and speech development, the questions and rationale. And finally, Table 11.9, Surveillance of Social and Emotional Development, the questions and rationale. The sleep-wake patterns and regulation. Discuss the need to assist children to transition from one state to another. Consistent sleep and nap time schedules are essential. Use of a comfort or transitional object, such as a teddy bear, and establishing a bedtime ritual will help. Explain how children process information, gain control, and how they can be overwhelmed if they have too much stimulation. Explain that some children may have sensory integration issues that require environmental structuring and modulation. Discuss how to help children identify and name their feelings. This ability will help them organize and integrate these sensations they experience and respond to appropriately. Encourage parents to provide opportunities for children to have some control and choice in daily activities, while maintaining important rituals. Discuss common sleep-related issues for this age group, including sleep resistance, bruxism, nightmares, and somnambulism, which will be discussed more in Chapter 16. Encourage parents to offer naps and opportunities for rest, but do not force them. Encourage parents to create consistent and comforting sleep routines for the child, provide positive reinforcement of healthy sleep behavior, and use firm, loving, and consistent discipline when dealing with sleep refusal and other behavioral sleep problems. And here is Table 11.10, the surveillance of cognitive development, the questions and rationale. Strength and coordination. Encourage parents to provide a wide range of safe play, opportunities that use both fine and gross motor skills. Urge parents to allow children to take the lead during play and to follow and expand on whatever the child is interested in. Encourage parents to provide a variety of play activities that expose children to nature, such as taking children to the playground to run through a balance, swing, and slide, as well as encourage play with natural materials, such as water, sand, grass, and leaves. Provide age-appropriate play materials, stickers, pencils, crayons, paper, paints, utensils, blocks, cardboard boxes, and building toys. Explain how parents can incorporate motor skills practice as part of daily routines. Emphasize the need for constant adult supervision of children's activities. Discuss how parents can make the environment safer for their child, securing doors and using window guards, removing toxic substances and dangerous objects, and providing toys that are developmentally appropriate and safely constructed. Reinforce teaching about car seat use and understanding when to transition booster seats as the child grows. Explain to parents the importance of modeling for the child for using their own seat restraint. And finally, encourage bicycle helmet use when riding toys, such as scooters, tricycles, and bicycles. Nutrition, self-care, and safety. Provide parents with information about age-appropriate nutrition. 3 meals and 2 nutritious snacks per day are encouraged throughout early childhood. Discuss it is the parent's job to provide nutritious foods and the child's job to decide how much they will eat of it. Starting with small portions of different foods will help the child choose a variety of foods. Discourage parents from making separate meals for their children. Young children may go on food jags, refusing some foods or requesting the same food day after day. Parents need to make sure food that is being eaten is nutritious. Explain how changes in eating habits can be due to developmental changes. Explain the non-nutritious value of food and eating, such as water, fiber, flavor, and aroma. And here is table 1111, the speech and language evaluation tools. Continuing on with our nutrition, encourage self-feeding to help the child gain new skills. Encourage parents to structure meal times that are pleasant and interactive. This may mean offering food that can be eaten in short periods of sitting. Avoid making meals a power struggle. Discuss plans for weaning. Explain the importance of the child gaining mastery of self-care, such as toileting, bathing, dressing, and eating, and the role that the parent plays as a teacher and role model. Assist parents to cope with the frustration or tension generated by children wanting to do it myself. Ask parents how they handle these situations. Encourage children to help with their self-care. They can brush their teeth and hair and clean up in the bath, and the parents can follow up to ensure that they did a sufficiently good job. Remind parents that injury is a leading cause of early childhood morbidity and mortality. Continued and updated child-proofing is needed, and choking foods must be avoided. And finally, parents should safety-proof all environments their children spend time in. They also need to be reminded that safety-proofing alone is not enough. Children need to have adult supervision at all times in this age group. Which brings us to behavioral, social, and emotional growth. Socio-emotional growth, development, and behavioral consequences are areas in which parents often need anticipatory guidance and support. In early childhood, children master multiple social tasks, as well as learning how to identify, control, and manage their feelings and emotions around anger, joy, love, and frustration. They learn about keeping friends, sharing, cooperative play, and living with family. They also learn to handle separation from parents, home, and neighborhood to help families with this process. Primary care providers should emphasize the role of parents as guides of their child's social and emotional growth. Encourage parents to give their children opportunities to expand social skills and form important attachments outside the immediate family. And they can do this by providing toys and other items that the children can use creatively, allowing children to explore, guiding them to activities that are fun and stimulate their curiosity, structuring time for children to play in natural settings. Access to green space enhances physical, mental, and emotional health of children. Allowing children to make choices when possible. Do not give children a choice when there really is none. Instead, use choices that allow the child to have a say and yet still get toward the final objective. Discuss similarities and differences among people openly and positively, helping children identify, name, and express feelings, both positive and negative. Teaching children how to manage anger and resolve conflicts without aggressive behavior or violence. Limiting screen time while being present to discuss television programs and movies they watch, especially when they need help distinguishing fantasy from reality. Taking children on trips of places of interest in the community. Arranging playtimes with other children, encourage cooperative play, and reinforcing positive behavior. And finally, making clear, consistent, and achievable expectations for the child. Differentiate discipline and teaching from punishment. Help parents resolve different expectations and present a united front. Provide information related to child development and what parents can expect their child to be able to do. For example, the CDC has developmental handouts available online. Recommend evidence-based parenting resources that provide information on developmental milestones, anticipated changes, and parenting strategies. Encourage parents to show affection in the family. Explain that myths and fables can be important ways of teaching children abstract concepts. To provide children a feeling of safety and security, parents should encourage comfort or transitional objects to allay fears. Consider providing a nightlight. Respond to children's nightmares or fears when they occur by offering ongoing reassurance. Explain about good and bad touch. And finally, reinforce that the child can always come to the parent for comfort. Which brings us to cognitive and environmental stimulation. Explain to parents that children in early childhood use concrete and pre-operational thinking. So as a result, parents need to be ready to explain things over and over patiently. Children may use words to convey thoughts and feelings, but many responses are repetitive, and trial and error problem solving is usually crude. They frequently attend to only one aspect of a problem, giving partial answers. Emphasize that parents should avoid putting their own meaning on the child's behavior or statement. For example, the child's statement, "What if you bought a new house and I had allergies or something in the house? I guess you'd have to get rid of me," should not be interpreted to mean the parents have somehow failed to show the child how much they love him or her. Rather, the child may be exploring the concepts of place, ownership, belonging, size, or importance. An appropriate response from the parent might be, "No, we'd probably have to get a new house or take out whatever is making you sick. Even if we just bought it, you are more important than any house, and we wouldn't want to lose you." Reassure parents that why will not continue to be the child's most frequent question. Children in early childhood actively explore meaning in their world and learn that asking why brings them more information and attention. As parents provide answers, children will show threads of symbolic and advancing thought process. Communication and language. Children learn and refine communication and language skills best through their interactions with others. When adults listen, talk interactively, and read to children, children's language blossoms. Encourage parents to stimulate their children's language skills by reading to children daily, using short, simple stories or picture books. Modeling appropriate language, explaining in clear, simple language what is happening around the child. This helps increase vocabulary and the child's understanding of the world. Quality, reciprocal speech is the best way to keep children learn to express themselves. Listening with care and responding actively to the child. Providing opportunities to interact verbally with other children and adults. Keeping screen time to a minimum. Children younger than the age of 2 should avoid all screens. After age 2, limit television viewing, smartphone, tablet, and video to less than 1 hour of developmentally appropriate programs per day. Children should not have screens in their bedroom. Watching programs with children and talking about what is happening. Primary care providers should emphasize the following anticipatory guidance. Explain that children need constant reinforcement of their speech and language efforts, but remind them that nonverbal language, especially touch, is equally important. Give parents an opportunity to share their expectations for their child. Discourage parental pressure on the child to perform, and point out that daily activities provide a wealth of opportunities to practice language skills. Reassure parents that early language errors usually disappear as the child grows, and finally inform parents that children develop receptive language skills first, then expressive. Children may not fully understand the meaning of what they say, especially connotative meaning. Parents should explain clearly, simply, and unemotionally which words are appropriate and which setting. Which brings us now to red flags. Although there is a wide range of typical development, the primary care provider needs to be alert to red flags, signs of delayed or abnormal development. In addition to obvious abnormalities, minor problems that are left untreated can develop into major concerns. Minor signs and symptoms that persist can indicate a more serious underlying problem, or a major problem can occur as a one-time event. Some children and families are at high risk and need careful monitoring and guidance to detect problems at an early stage or to prevent their occurrence. These warning signs or red flags can be found in Table 11.12. Each red flag warrants follow-up, immediate referral to required for children who stop eating, demonstrate cruelty to animals or other people, are self-harmful, start fires, or talking of harming themselves, their peers, or others. Physical red flags. Children should be monitored for physical growth milestones. Further investigation and referral may be appropriate when children deviate from an established growth pattern or percentile, whether it is an increase or decrease. Some children have overt symptoms. They stop eating, complain of tiredness, are not as active as usual, or the parents state that their child regressed. Growth pattern changes always warrant further investigation. Cognitive. Cognitive delays are difficult to recognize and categorize. Screening tools help to determine variances from typical development. Some tools rate child development based on a standardized score or against standardized criteria. For example, children with scores below 85 on intelligence scales predictably have difficulty in school. Significant discrepancies between test scores taken over time also suggest problems. The causes must be carefully assessed, as some children may have a neurological limitation, whereas others may be delayed because of material or environmental deprivation. However, identifying the cause is necessary to plan effective interventions. When delays are suspected, prompt referral to a developmental specialist or early childhood intervention programs for more detailed assessment and intervention is essential. So here we'll take a look at red flags in early childhood, different ages, growth, rhythmic sleep and temperament, psychosocial and emotional skills, cognitive abilities, whether it's a gross motor or fine motor, and finally strength and coordination. And here it continues some more, just different age groups. Language delays or disorders can affect other areas of development, especially cognitive, behavioral, social, and emotional development. Because language development is the best indicator of cognitive development, language delays may indicate serious issues requiring intervention. Children with language delays can experience problems in receptive or expressive language. They may start talking late, talk very little, or have prolonged stages of stuttering, distortion, and substitution. Cognitive, familial, environmental, physical, psychological, or cultural factors can lead to language delays. Language delays or disorders may also occur if the child does not hear or is not immersed in a language-rich environment, or has a disorder, such as a severe deprivation or autism. Speech disorders are often associated with specific physical problems, but they can be also idiopathic. Language evaluation involves assessment of the child's physical, cognitive, social, emotional, and perceptual abilities. Evaluation should include both expressive and receptive language. The inability to use the symbols of language may be characterized by improper use of words and their meanings, Inappropriate grammatical patterns, improper use of speech sounds. Speech disorders involve problems producing correct speech sounds and may be characterized by difficulty, such as producing speech sounds, maintaining speech rhythm, controlling vocal production. Management of children with language disorders requires a clear understanding of the nature of the problem. Referral to a specialist to make that determination is often the first step. Deficits identified in Table 1111 are a cause for referral for additional testing. Other criteria that warrant referral would also include unusual connected speech confusion, reversals, or telescoping, a loss of previously acquired language skills, the child stops talking, the child reacts to their own speech with embarrassment or withdrawal, the child's voice is monotone, extremely loud, largely inaudible, or of poor quality. Pitch is not appropriate to the child's age and sex, and finally, hypernasality, or lack of nasal resonance, occurs. Which leads us to our additional resources. The ones listed here today are the AAP parenting website, Bright Futures, the CDC, especially the Essentials for Parenting Toddlers and Preschoolers, as well as Learn the Signs, Act Early, information for parents of infants and toddlers for ages 0 to 3 or 4 to 11, and then the Personal Safety for Children, a Parent's Guide, and 0 to 3. Which brings us to our references. That should conclude our chapter here today. I thank you as always, and I'll see you at the next chapter. Till then, take care and goodbye.